Hello student. Now we are going to quickly revise reproductive and endocrine physiology. You know that these topics, the selective questions have been asked in MCQ. So you have to quickly revise these two topics and always read endocrinology with the help of medicine. So first there is an MCQ. Which statement about peptides or protein hormone is usually true? So you know two major groups of hormones are there, proteins and peptides, and the steroid one. So steroid, they are lipophilic, they can easily cross the plasma membrane, and after crossing the plasma membrane they attached with their receptor, which is generally located either in the cytoplasm or within the nucleus. But protein group of hormone, they cannot cross the plasma membrane, so their receptor must be present on the cell membrane. So the first thing, they have receptor on the cell membrane. This is absolutely and true statement about the protein hormone. Now the second thing is that whenever the receptor is present on the cell membrane, whenever you are stimulating the receptor, it will activate one second messenger system, and through the second messenger system the onset of action of the hormone is very rapid. So protein group of hormone, they have very rapid onset of action. But steroid group of hormone, you know, the steroid group of hormone, they ultimately act through gene expression, genomic expression. So whenever you want to express genes and followed by protein expression, it takes long time. So the action is completely slower in comparison to the protein hormone. So the protein hormone has a slower onset of action. This is a false statement. They are not stored in endoplasmic reticulum. So protein, they are generally produced by rough endoplasmic reticulum, and they are packed inside certain vesicles or granule at the level of Golgi body, and they are secreted from this granule. So they are generally stored, they are not stored. This is also a false statement. And if I look at the first statement, they have longer half-life. So we all know that protein hormone, normally they remain free in the blood, and whenever one hormone is free in the blood, their half-life will be less because they can easily be excreted from the blood. So this is also a false statement. So answer of this question is B, right? So protein hormone means they normally generally remain free in the blood, so short half-life, membrane receptor, faster action, and they secreted as a granules. Okay. Now second, all of the following hormone have intracellular receptor except. So again, this is one of the question where they have asked multiple times that what are the hormones which have intracellular receptor. Intracellular receptor means receptor may be present at the level of cytoplasm also, receptor may be present at the level of nucleus also. I hope all of you know, right? But whether the receptor is present at the level of cytoplasm or nucleus, ultimately the hormone receptor complex will act through nucleus only. That's why sometimes we say they are nuclear receptor. But according to the location, it may be cytoplasm or it may be nucleus. Now, all of the following hormone has intracellular receptor except. So this thyroid hormone has intracellular receptor. This glucocorticoid steroid hormone also has intracellular receptor. This androgen also have intracellular receptor. So answer is obviously glucagon. The classification of the hormone receptor. So we are discussing that membrane receptor is there for protein or peptide groups of hormone. The membrane receptor again can be classified into 5 different subcategories. What are they? GPCR. This is nothing but G protein coupled receptor. Guanine cyclase receptor, tyrosine kinase receptor, cytokine receptor, and serine kinase receptor. I will give you the examples of all of this hormone, but the detailed mechanism will not be discussed in this brief discussion, right? Then second is the intracellular receptor. Intracellular receptor means this hormone will act through the nucleus. That's why sometimes we say as a whole that this is nuclear receptor. But they are asking controversial question that intracellular receptor means whether the receptor is actually located within the cytoplasm or within the nucleus. And this is one of the most important controversial area where different books have given different answer. Okay, but what I follow or what I have given the references in my main lecture also, that nuclear receptor, the receptor directly present in the nucleus for thyroid hormone, vitamin D, and vitamin A receptor. So there is controversy regarding this vitamin D receptor, but I am telling you with some reference also, and there are other books also which are saying that vitamin D is cytoplasmic receptor. On the other hand, cytoplasmic receptor, this is a glucocorticoid receptor, mineralocorticoid receptor, androgen receptor, estrogen and progesterone receptor. All of them have their cytoplasmic receptor. Again, there is a controversy regarding this progesterone, but you can follow any of the teacher which you are believing, right? So don't waste your time by putting into your controversy. So now next is that when the hormone is a G protein, when the hormone has a membrane receptor, I told you that there are different sub variety, 5 different subtypes. Look at, if the hormone is acting through a G protein coupled receptor, so the G protein first it will be activated, then the G protein can be of different type. If it is stimulatory G protein, then it is known as the alpha GS alpha basically. So there are alpha subunit, beta and gamma subunit in the G protein. So you know that alpha subunit, if it is stimulatory G protein, then it is known as alpha S. Inhibitory G protein, alpha I. And there is another type of G protein which is known as the alpha Q, GQ type of G protein. So this is GQ type of G protein, this is GI type of G protein, and this is GS. So GS means stimulatory. It will stimulate the AC, adenine cyclase, that is an effector. And through this effector stimulation, the second messenger that will be increased is CAMP. GI means it will inhibit the adenine cyclase and CAMP will be decreased. And when it is GQ, it will stimulate the phospholipase C. Through the phospholipase C, DAG and calcium will be increased. So this is one of the important area where you can find out that calcium is one of the messenger system in this pathway. And through this messenger system, what is happening, ultimately the physiological effect of the hormone will be seen, right? So we have to remember the hormones which are acting through this GS, okay, which is acting through this GI and which is acting through the GQ. But among these three, the most important is that I have to remember what are the hormones which act through GQ type of G protein coupled receptor. Now I told you the second group of receptor is the tyrosine kinase type of receptor. So here is the guanine cyclase type of receptor. I will tell you the examples of this. Tyrosine kinase type of receptor, it can activate two different intracellular pathway. One is RAS, RAP and MAP kinase pathway, and second one is the AKT and MAP kinase pathway. You just try to mug up this information for the time being, okay, because it is rapid division. So the hormone which act through this RAS, RAP and MAP kinase pathway is the epidermal growth factor and the nerve growth factor, right? And AKT and MAP kinase pathway, insulin and IGF are the hormones. Similarly, the cytokine receptors, okay, this is analogous to the tyrosine kinase receptor. It activates the intracellular pathway that is known as the JAK-STAT pathway. Very, very important for MCQ. I have to remember growth hormone and prolactin. They are the tyrosine kinase analogous receptor and they activate the JAK-STAT pathway. And serine kinase receptor, they activate the SMAD pathway. SMAD pathway, what are the hormones which are acting through the SMAD pathway? MIS, that is the Mullerian inhibitory substances, and activin. So these are the brief discussions of all the membrane receptor putting into a single slide. You try to remember that what are the hormones acting through them. I will tell you the detail. Okay. Now, rather than membrane receptor, if you look at the steroid hormone receptor, okay, so because they are the lipophilic hormone, they can easily diffuse through the cell membrane. So this is the hormone which has entered into the cytoplasm. Now the receptor of the hormone can be located directly at the level of cytoplasm, as you can find out here, or the receptor of the hormone can directly located at the level of nucleus. But whether it is at the level of cytoplasm or at the level of nucleus, whenever the hormone attaches with its receptor, ultimately the hormone receptor complex has to translocate at the level of nucleus. And after reaching at the level of nucleus, how it is going to act? It is going to act via gene expression. That's why we say that the steroid hormone, typically they have genomic action. Typically they have genomic action because they act through expression of various genes. And steroid hormone, they are nuclear receptor, because whether the cytoplasmic receptor is there or nuclear receptor, ultimately the function is happening through nucleus. So sometimes broadly we say they are the nuclear receptor, they have nuclear receptor. But question specifically asked that whether the nucleus is already present in the cytoplasm or already present in the nucleus. Okay, that type of question has been asked, which we have already discussed. Okay, now you look at the examples of different hormones. So I told you that G protein coupled receptor, it can be GS or GI or GQ. I told you specially that you have to remember the names of hormone in the category of GQ. What are the hormone? TRH, GnRH, GHRH, growth hormone releasing hormone, oxytocin, ADH, acting through V1 receptor. Please remember, ADH has V1 and V2 receptor. V2 receptor act through this. Okay, that is the CMP, increased CMP. But V1 receptor, they act through this IP3DG, and IP3DG means ultimately the calcium is going to be released. Okay, not only that, the alpha-1 adrenergic receptor and acetylcholinergic M1, M3 and M5 receptor. They are also examples of this GQ type of G protein. This is very, very important. I told you already many question has been asked from this area. Okay. Now second is that guanine cyclase receptor. This is also important for MCQ. What are the hormones that act through guanine cyclase receptor? ANP, atrial natriuretic peptide, and the second one is the endothelin derived relaxation factor, which is nothing but the nitric oxide. So basically ANP and this endothelin derived relaxation factor, these are the two names that you have to remember for guanine cyclase receptor. Then I told you earlier already these examples we have discussed that under tyrosine kinase receptor, the intracellular pathway can be this MAP kinase pathway, AKT pathway also, or it can be RAS, RAP, MAP kinase pathway also. So it is RAS, RAP and MAP kinase. Then the hormones are epidermal growth factor and nerve growth factor, and this insulin and IGF-1 they act through the MAP kinase and AKT pathway. I told you the more important is the JAK-STAT pathway. Through this pathway, the growth hormone and prolactin act. This is a cytokine kind of receptor, but it is analogous, similar to the tyrosine kinase receptor. And the serine kinase receptor activate the SMAD pathway. The hormones which act through this is the activin, TGF-beta, and Mullerian inhibitory substances. So, in endocrine physiology, the most important thing is this hormone receptors. Okay. Other things, some part you can easily answer from the knowledge of your medicine. But this receptor part you must have to read from physiology at least. Okay. Now look at this. MCQ regarding a 45-year-old woman has a mass in the sella turcica, compresses the portal vessel. Got it? Okay. Disrupting the pituitary access to the hypothalamic secretion. So we all know that if this is the hypothalamus, there is a pituitary stalk. Through this pituitary stalk, anterior and posterior pituitary is there. So all of these anterior pituitary trough cells, they are basically under the stimulatory control from hypothalamus. So hypothalamic hormone generally stimulate them, but except one, which is under the inhibitory control, and that is nothing but the prolactin. So whenever there is disruption of this stalk by any tumor or anything, what will happen? All of the stimulatory pathway will be cut down. So all the secretion of all hormone like the ACTH, like the TSH, all of them will be decreased. But the prolactin was under inhibitory control. So what will happen? The prolactin level is going to be increased. So that's why the secretion rate of which of the following is most likely to increase? Your answer will be prolactin. Okay. So look at this, whole control has been given here. So gonadotropin releasing hormone. Okay. It is acting at the level of pituitary for production of LH and FSH, stimulatory control. TRH, it is acting at the production of TSH, it is also stimulatory control. But look at here, the dopamine, which is controlling the prolactin production from anterior pituitary, it is under inhibitory control. So this dopamine is coming from the hypothalamus. It is known as the prolactin inhibitory factor. Okay, normally it is inhibiting the prolactin production from anterior pituitary cells, right? But here you look at GHRH, growth hormone releasing hormone. It is a stimulatory for the anterior pituitary growth hormone production, but somatostatin is also there, which is an inhibitory for this growth hormone production. So for the growth hormone, both stimulatory and inhibitory factor are there. And CRH, it is a stimulatory for the ACTH production from anterior pituitary. And for posterior pituitary, you all know that ADH and oxytocin is there. But one thing you have to remember here. See here, there is one bypass pathway. The TRH, generally it stimulates the TSH production. But if the TRH is very high, like for example, suppose on primary hypothyroid patient, TRH level is very high, then this TRH can stimulate the production of prolactin. So in case of primary hypothyroid patient, if the TRH level is very high, prolactin level can also increases because TRH gives additional stimulation to this prolactin hormone secretion. Got it? So these are the things that you have to remember for your MCQ. Now, which of the following condition or hormones would most likely increases growth hormone secretion? So whenever it is growth hormone, you have to remember that growth hormone increases your blood glucose level. So any stimulus which is decreasing your blood glucose level, hypoglycemic condition, that is a stimulus for growth hormone secretion. Okay, so hyperglycemia is not a stimulus. If you are doing exercise, your cellular hypoglycemia will be there, so it will increase the growth hormone secretion. Yes. Somatomedin is the mediator of the growth hormone. Somatomedin is also known as the IJ. So growth hormone generally produces somatomedin from the liver, and somatomedin do some of the actions. Somatostatin do some of the actions of growth hormone. It is a mediator of the growth hormone action. Somatostatin is an inhibitor of the growth hormone production. So only answer that is possible here is exercise. So I must have to remember that what are the stimulus for growth hormone production, because this has been asked multiple times in MCQ. So number one is the hypoglycemia, okay, one of the most potent stimulus for growth hormone production. Second is the increased amino acid in the plasma. So whenever you are taking protein containing food, meal, your amino acid level in the blood will be high, and that's a stimulus for growth hormone secretion. Third is any kind of stressful stimulus, whether it is mental stress or physical stress, surgical or traumatic stress, that will also increase your growth hormone. And the fourth one is the sleep. So in sleep, you particularly remember, it is the non-REM sleep which is the stimulatory. REM sleep is the inhibitory for growth hormone. Although REM sleep is a stimulatory for prolactin hormone, LH hormone, FSH hormone, right? REM is a stimulatory, but REM is an inhibitory for growth hormone. Please remember, this is very, very important for MCQ. Okay. Now, last thing that you have to remember about growth hormone is growth hormone functions. This has also been asked in multiple MCQ. So, growth hormone has some direct action. So, all the yellow color boxes that has been given here, they are the direct action of growth hormone. Means growth hormones are doing all of this job. Okay. So, increase bone growth, increase protein synthesis, increase sodium and water absorption, okay, decrease glucose uptake in the cells, so it is a diabetogenic hormone, increase insulin resistance. So all of these are done by direct action of growth hormone, right? But growth hormone stimulate the liver and it produces IGF, insulin like growth factor, which is also known as the somatomedins. And through this somatomedins, what the growth hormone is doing, it is increasing the protein synthesis. It is increasing the protein synthesis in the muscle. It is increasing protein synthesis in the chondrocyte, as well as it is also doing the anti-lipolytic activity. So please remember all of these actions. You may get MCQ from here. Okay. So next is, which physiological response is greater for T3 than T4? So basically you are doing a comparison between T3 and T4. So what we know from our basic knowledge, T4 is a major hormone which is secreted by the gland, but T3 is more active than T4, right? So these are the basic things which I keep inside my mind. So secretion rate from thyroid. So which of the following is greater for T3 than T4, right? So secretion rate from thyroid, no, it is greater for T4, okay? So T4 is greater than T3 here. Plasma concentration, obviously T4 secreted more means plasma concentration will also be more. Plasma half-life, T4 has a half-life of 7 days and T3 has a half-life of 1 day. So all these are more in case of T4. Affinity for nuclear receptor, this is more in case of T3 than T4, because whenever your affinity is more for the receptor, your onset of action, your rapidity of action, okay, will be also more stronger. So that's why we know that T3 is more active, okay, more faster onset of action than T4. Okay, so T3 is more active and more faster than T4. Okay, so look at this difference between T4 and T3. So this is T4 and this is T3. So T4, as you can find out here, secretion is more, 80 microgram per day, but here it is only 4 microgram per day. Plasma concentration 8 nanogram per dl. Here this is only 0.15 nanogram per dl. In case of half-life, 5 to 7 days in case of T4. It is only 1 day in case of T3. But look at potency. So T4 is slower and T3 is faster. Potency is less potent. It is 3 to 5 times more potent. Binding to thyroid hormone receptor, less affinity binding, more affinity binding. So these are the important things that you have to remember between T3 and T4. Okay. Next, a person presented with puffy skin and lethargic. So this is giving an indication that the person may be suffering from hypothyroidism. His TSH level are low and are improved on administration of TRH. So when the TSH level is low, what I will think? I'll think that the problem may be at the level of pituitary, so pituitary is damaged, or maybe the hypothalamus is damaged because the hypothalamus is not producing adequate amount of TRH. That's why the TSH level is less. So their problem may be at two levels, maybe at the hypothalamus, maybe at the level of pituitary. Now the second part of the question is saying that TSH levels are improved on administration of the TRH. So whenever you are giving TRH injection externally, TSH level is rising. So where from the TSH producing in these cases? Obviously pituitary. That means pituitary is absolutely normal in these cases. But the problem lies at the level of hypothalamus. So these are typical cases of hypothyroidism because the patient is present with the puffy skin and lethargy. But hypothyroidism is not due to problem at the level of pituitary. Problem is at the level of hypothalamus. Hypothalamus is not producing adequate TRH, that's why TSH low, that's why T4 is also low, and the person is suffering from hypothyroidism. So this kind of hypothyroidism is known as tertiary hypothyroidism, where hypothyroidism because of hypothalamic defect is the typical answer. Whenever we classify the hypothyroidism or hyperthyroidism, you have to look at the three types: primary hypothyroidism, secondary and tertiary hypothyroidism. So whenever I am saying primary hypothyroidism, problem is at the level of thyroid gland. Secondary, problem is at the level of pituitary. Tertiary, problem is at the level of hypothalamus. Now look at, if there is primary hypothyroidism, so problem is at the level of thyroid gland is destroyed. So which hormone production will be decreased at the beginning? T4. So that's why I put it into circle. But if the T4 is less, so negative feedback on pituitary and hypothalamus will be less. So if the negative feedback is less, what will happen? TSH will rise and TRH will also rise. Got it? So that's why TSH, TRH is high but T4 is low. This is typical of primary hypothyroidism due to thyroid problem. But if the pituitary is damaged, so the first hormone that is going to be reduced in this condition is the TSH. So that's a problem is arising from here. Problem is arising from here. So in the first cases, problem was arising from T4. But here the problem is arising from TSH. So pituitary is defective. TSH is not there. So T4 will also be decreased. So that's why again the person will suffer from hypothyroidism, right? But this hypothyroidism is originating at the level of TSH problem, which is secondary hypothyroidism. And the TRH will be high because the negative feedback is not there. But in case of hypothalamic defect, the problem is originating from here. TRH is low, that's why the TSH is low, that's why the T4 is low. So again the person is hypothyroid, but this is tertiary hypothyroidism. Problem is originating at the level of hypothalamus. Very, very important. Similarly, hyperthyroidism, primary thyroid problem, secondary pituitary problem, tertiary hypothalamic problem, right? So primary means T4 is high because of the thyroid gland problem. Secondary hypothyroidism means T4 is high because of the TSH is high. And tertiary means hypothalamic TRH is high. That's why the TSH as well as the T4 level is very, very high. So these are the basic concept about the different types of hypothyroid disease that you have to remember is here. Now next question. In comparison to normal healthy person in the evening time, which among the following have elevated both ACTH and cortisol? So if you compare with the evening level, which of the following has more ACTH and cortisol level? So we all know that cortisol as well as ACTH has a diurnal variation. Okay, let's follow a circadian rhythm. There is an diurnal variation. What do you mean by diurnal variation? Means the highest amount of ACTH as well as cortisol is released at the level of morning. So cortisol ACTH level is high, that's why cortisol level is also high. This is at the level of morning time, particularly at 8:30 am. And the minimum level or the lowest level of ACTH as well as the cortisol is seen at which level? At the in and around midnight level, in and around midnight, right? So this variation, this fluctuation will follow a 24-hour rhythm. Means it is high at 8:30 am in the morning, again it is low in midnight, again it is high at 8:30 am in the morning. So this is 8:30 am in the morning, this is also 8:30 am in the morning. If I ask you what is the gap between these two peak points, obviously the gap is approximately 24 hours. This kind of rhythm is known as the circadian rhythm or diurnal rhythm. So in comparison to this evening level, morning ACTH level and morning cortisol level will be higher, obviously. So if I look at this question, in comparison to normal healthy person in the evening time, so in the evening time ACTH and cortisol level is low. Okay, ACTH and cortisol level is low in a normal healthy person in the evening. In comparison to this, just after awakening in the morning. So in the morning time, ACTH and cortisol level will be high. So this is a true statement. Then a person who is suffering from Cushing disease. So Cushing disease means we all know that it is Cushing syndrome due to pituitary adenoma. So pituitary adenoma is producing huge amount of ACTH. Because of the huge amount of ACTH, the cortisol level is very, very high and the person is suffering from Cushing syndrome. So this is also a true statement, means a person who is suffering from Cushing syndrome or Cushing disease, not the Cushing syndrome, the Cushing disease, the ACTH and cortisol level is also very, very high in comparison to the evening level of ACTH and cortisol. So both are true. But if I look at the difference, then in case of Cushing disease, the ACTH and cortisol level will be very, 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 very high in comparison to normal person. So if I have to choose a single best answer, I'll go for the Cushing disease. Although just after awakening in the morning, it will also have a higher value of cortisol and ACTH in comparison to the evening value of ACTH and cortisol. Got it? So this is the answer of this question. Okay. Now coming to the next, which is not seen in case of ACTH deficiency. So if there is ACTH deficiency, what will happen to the production of the adrenal cortical hormone? Adrenal cortical hormone production will be very, very low, and that can sometimes leads to secondary addition disease. I'll show you. Okay, I'll tell you. But note down here. Which of the following is not seen in? Remember, if the ACTH level is very, very high, then it cross-react with the melanocortin receptor type 1 and it stimulates the melanocyte, which causes hyperpigmentation. So when this hyperpigmentation will be seen, if the ACTH level is very, very high. So hyperpigmentation in case of ACTH deficiency is not a feature. Rather, if the person is suffering from ACTH deficiency, there will be severe pallor rather than hyperpigmentation. So this is the answer of this question. But I am telling you that this question can be answered in a different way also, that if the ACTH is deficient, then the person can also suffer from secondary adrenal insufficiency, as it is written here. It is the consequences of dysfunction of the hypothalamo-pituitary axis, which suppresses when the ACTH level is very, very low. That is a secondary addition disease. Primary addition disease, you know that the problem originate at the level of adrenal gland itself. The adrenal gland is destroyed. Why it will be destroyed? It may be tuberculosis of the adrenal gland, it may be autoimmune destruction, or maybe other disease like HIV, metastatic carcinoma, adrenectomy. So in all of this condition, whenever your adrenal gland is destroyed, from the adrenal gland, the glucocorticoid hormone which was produced, will be deficient. The mineralocorticoid will also be deficient. The sex steroid will also be deficient. Right. So whenever they are deficient, what will happen? Okay. What will happen? The hypoglycemia, okay, will be seen. The fatigue, the weight loss, the muscle and joint pain will be there. In case of mineralocorticoid deficiency, hypotension is one of the important feature. Postural hypotension will also be there. And sex steroid, lack of energy will be there. Dry and itchy skin will be there. But remember that if it is primary adrenal destruction, that is the typical addition disease, then what will happen? Because the adrenal cortex is destroyed, ACTH level will be very, very high because of the loss of negative feedback. So ACTH level, whenever it is excess, I already told that hyperpigmentation of the skin is going to happen. But in case of secondary adrenal insufficiency, okay, generally it is not known as addition disease. The primary one is known as addition disease. So in case of secondary adrenal insufficiency, this hyperpigmentation is not going to be seen because here the ACTH level is low, and because the ACTH level is low, the person will suffer from additions like symptoms, adrenal insufficiency. Getting my point? So these are the symptoms of addition disease, which is nothing but primary adrenal deficiency. Now next is, which hormone has permissive role in puberty? Okay, so question is permissive role. Permissive role means, the presence of certain hormones is required for full functions of other hormones. So leptin, it cannot help in onset of puberty. Okay, the main hormone which is responsible for the onset of puberty is the GnRH. We say that pulsatile release of GnRH is responsible for or one of the main cause of onset of puberty. But certain amount of leptin, small amount of leptin is essential for proper functioning of this GnRH hormone. This kind of functions is known as the permissive action. So leptin per se cannot causes onset of puberty, but presence of leptin is essential for full function of this GnRH hormone. That's why we say that leptin has permissive role for GnRH, permissive role for onset of puberty. So you have to remember certain information about leptin because this is one of the important topic in MCQ. Leptin releases from white adipose tissue, fat cells. So whenever your fat cells masses is more, blood level of leptin will be also more. So if the person is fat, fatty person, the leptin level in the blood will be higher. And if the person is lean and thin, then the leptin level in the blood is low. But look at, more the adipose tissue mass, more is the amount of leptin that I already told. Leptin sends anorexigenic signal, satiety signal to the hypothalamus. So if a person is very fatty person, obese person, leptin level is already high in the blood, and that leptin is giving a signal to the hypothalamus that please reduce your food intake because you are already obese, right? So that way, please remember, whenever the person is obese person, leptin level is high, but leptin sends anorexigenic signal to hypothalamus. Got it? Okay. Leptin also stimulates thermogenesis, and leptin has permissive role in the onset of puberty. It regulates the circadian rhythm of the gonadotroph cells, and it also increases the pulsatile rate of GnRH secretion, because I was telling that this pulsatile release of GnRH is one of the essential feature of onset of puberty. Now next, after ovulation, corpus luteum releases which of the following hormone? We all know that after ovulation, the corpus luteum releases progesterone hormone. So this is a direct answer. Full development and function of the seminiferous tubules. So seminiferous tubule has receptor for FSH. Single most important hormone which is required for seminiferous tubular development is FSH, but along with FSH, testosterone is also required. So androgen and FSH will be best answer in this question. So option number D is the answer here. Now in male, testosterone is secreted from. So this kind of similar questions is asked from the reproductive physiology. Don't look at me that said these questions are very simple. This kind of questions have been asked in NEET entrance examination also, and future also from reproductive physiology questions will be simpler. Got it? So what you have to remember, you can understand from here that for male reproductive system, at least I have to read about the Sertoli cell, at least I have to read about the Leydig cells. So look at, so this is the cross section area of the testis where you can easily find out the location of this Sertoli cell. So this is the location of the Sertoli cell. Okay? So this is one of the Sertoli cell, and this is another Sertoli cell here. Okay, so these two Sertoli cell, they're connected with one another by a cytoplasmic bridge, and that produces a barrier which is known as the blood testis barrier. So blood testis barrier is formed by the Sertoli cell. Please remember this Sertoli cell, right? Okay. Now this Sertoli cell is one of the important cells which is responsible for proper development of the spermatogenesis. Okay, proper development process of spermatogenesis. And outside this basal lamina, you can find out another cells, and this is nothing but the Leydig cells. So Leydig cells, we all know that LH has receptor on this cell, and the FSH has receptor on this Sertoli cell. And this Leydig cell is going to produce the testosterone hormone. Then this testosterone hormone will enter inside this compartment and it will help in the spermatogenesis process. This is the basic thing. So what I have to remember? I have to remember about Sertoli cell, I have to remember about Leydig cell. So Sertoli cells, I told you that it forms a blood testis barrier. It nourishes and protects the developing sperm. Okay, and it contains the receptor for FSH and androgen. They also produces androgen binding protein. What is the importance of this? So whenever this testosterone from the Leydig cell is entering inside the compartment, this testosterone has to be attached with some binding protein, and that is nothing but androgen binding protein. which cell is secreting them? The Sertoli cell is going to secrete them. So please remember that they also secrete androgen binding protein. Sertoli cell express aromatase enzyme, very important. And this aromatase enzyme can convert the testosterone which is entering here. That testosterone can be converted into little amount of estrogen, and this estrogen has also important for spermatogenesis process. Now the Sertoli cell also produces extracellular matrix component and also produces Mullerian inhibitory substances. Inhibin B is also produced by the Sertoli cell, which is one of the most important testicular contribute to the negative feedback suppress of FSH. So we all know that FSH stimulating the Sertoli cell will produce inhibin B will inhibit the FSH production, negative feedback process. Now the Leydig cell on the other hand, so Leydig cell is going to produce the testosterone, steroidal hormone. So what is the raw material for steroidal hormone? The cholesterol. So this Leydig cell can synthesize this cholesterol de novo, as well as it can acquire the cholesterol through this LDL and HDL receptor. So the scavenger receptor is present on this Leydig cell, through which it can take the LDL from the blood, or it can synthesize LDL de novo within the cell. Okay, and from this cholesterol ultimately the testosterone is going to be formed. But the enzyme which is required for special production of this testosterone is the 3-beta hydroxysteroid dehydrogenase, that you also have to remember. Now next is that we already told that testosterone diffuses into the seminiferous tubule, and some of the testosterone can be converted into estrogen by aromatase enzyme, right? Aromatase of the Sertoli cell convert into estradiol, already told. Sperms expresses estrogen receptors. I told you that estrogen is also required for spermatogenesis process. Sperms has this estrogen receptor, and this estrogen helps in acrosome synthesis of the sperm. Got it? Very important. So testosterone is converting into estrogen. Estrogen has its receptor on sperm cells, and how estrogen is helping in spermatogenesis? By synthesis of the acrosomal cap. Now the last questions of this rapid revision is one question from practical physiology, practical MBBS. Okay. Rees-Ecker fluid is used as a diluent for which of the following pipette? So as you can find out here, this is an hemoglobin pipette, this is an RBC pipette. I hope all of you know that in RBC pipette the marking here is 101 and here it is 1, and in WBC pipette here it is 1, here it is 11. So this is the WBC pipette, and in hemoglobin pipette there is only one marking, that is 20 microliter, right? And the last one, all of you know from your pathology knowledge that this is nothing but Windrow tube. Okay, so Windrow tube marking, we all know that in one side 0 to 10 and in the other side 0 to 10. So this kind of marking on both sides is present. This is Windrow tube. So now you tell me, Rees-Ecker fluid is used for which of the following thing? You know, Rees-Ecker fluid is used for counting platelet, and this platelet is counted in RBC pipette. So that's why the RBC pipette here is B. So the B is the answer in this question. So how to remember? You just have to remember the name of certain fluid which is used for different cell counting. Like for example, hemoglobin estimation is done by Sully's acid hematine method, where HCl, N by 10 HCl is used. Another method is also there for hemoglobin estimation, that is the cyan meth hemoglobin method, where Drabskin solution is used. At least you remember these two names. Okay. Now for RBC counting, Haem's fluid is used typically, which is nothing but a NaCl solution. Sometimes formalin citrate can also be used. Okay. For WBC countings, the fluid that is used for WBC counting is Turk's fluid. Okay. And for platelet counting, ammonium oxalate and Rees-Ecker fluid, these are the solution that is used for platelet counting. So this is all about rapid revision of physiology. The end. Thank you so much.